Today we'll discuss another topic in ophthalmology, that is viral conjunctivitis. It is a common extraocular infection. In 90% cases, adenovirus is the causative agent. It may be sporadic or occur in epidemics. Clinical hallmark of most viral conjunctivitis is follicular reaction of the conjunctiva, although this feature may also be present in chlamydial infection and toxic conjunctivitis as well. What is toxic conjunctivitis? It is an ocular surface medicamentosa, and it is due to chemical toxicity or a delayed cell mediated hypersensitivity response of the ocular surface and adnexa to active drugs or preservatives. It may occur due to aminoglycoside antibiotics such as gentamicin and tobramycin, antiviral drugs such as trifluorothiamidine, many glaucoma drugs such as brimonidine, timolol, and pilocarpine, as well as due to some topical anesthetics. What are the various causative agents? We need to know this list. That is, adenovirus conjunctivitis is the most common causative agent in more than 90% cases. Herpes simplex keratoconjunctivitis, herpes zoster conjunctivitis, picornaviruses like enterovirus and coxsackie pox virus conjunctivitis, myxovirus conjunctivitis, and paramyxovirus conjunctivitis. What are the symptoms? The patient will present to us with usually with the following symptoms: watering, redness, irritation, itching, and photophobia when the cornea is involved. Signs. Signs. We'll discuss them in the order of anterior to posterior. Eyelids. They are usually edematous, and the edema may range from mild to being severe. Lymphadenopathy is very common, and it causes tender preauricular lymph nodes. Conjunctiva. We see many hyperemic follicles. There may also be presence of papilla. In these images, we compare the papillary conjunctivitis with follicular conjunctivitis. Keratitis. It is usually due to the adenoviral species. Epithelial microcysts occur in the early stage. These may lead to punctate epithelial keratitis in 7 to 10 days after the onset of symptoms, and these resolve in the 2 weeks, followed by stromal infiltrates and subepithelial infiltrates, which may persist for months or years, causing visual debilitation to the patient. Anti-uveitis is usually mild, whereas in many cases it can lead to severe inflammation, which is associated with conjunctival hemorrhages, chemosis, and pseudomembranes. These may sometimes even lead to conjunctival scarring. This image compares the true membrane with pseudomembrane. As you can see, the pseudomembrane is being peeled off with the help of forceps. This image shows when we try to remove the epithelium, the true membrane, which is stuck to the epithelium, it will cause bleeding underneath, whereas the pseudomembrane uh, does not. This table enumerates the various differences between true membrane and pseudomembrane. It involves inflammatory exudates intergirated with superficial layer, inflamed conjunctival epithelium. Removal of true membrane leads to tearing and bleeding. Neisseria gonorrhoeae, Corynebacterium diphtheria, and SJS are the common causes. Pseudomembrane. It involves coagulated exudates adherent to the inflamed epithelium. These can be peeled away easily, leaving the underlying epithelium intact without any bleeding. These occur in epidemic keratoconjunctivitis, allergic conjunctivitis, and very severe bacterial conjunctivitis. So, how do you go about examining a patient when we can visualize follicles? Then we look for preauricular lymph nodes. If there are no preauricular lymph nodes, then it is usually toxic conjunctivitis or molluscum associated. If the patient has preauricular lymph nodes, then we look for herpetic signs like dendrites and skin lesions. If dendrites or skin lesions are present, it is usually suggestive of herpes simplex virus, and if not, it can be adenovirus or chlamydia. Adenoviral conjunctivitis. It is usually a non-enveloped, double-stranded DNA virus which replicate within the nucleus of host cells, and it acts as a general reservoir only in humans. There are various manifestations of adenoviral conjunctivitis: epidemic keratoconjunctivitis, non-specific acute follicular conjunctivitis, pharyngoconjunctival fever, and chronic relapsing adenoviral conjunctivitis. The spread of infection is facilitated by viruses which can survive on dry surfaces for weeks, or by viral shedding for many days before clinical features are apparent. Transmission occurs by contact with respiratory or ocular secretions or via contaminated fomites such as towels. Route of transmission is usually eye, hands, eyes, or in clinical settings it can be eye, instruments, eye. So we'll discuss the most common entity, that is the epidemic keratoconjunctivitis. It is also the most severe presentation. We should remember that it is caused by adenoviruses type 8, 19, and 37, and it is markedly contagious. The incubation period is about 8 days, and the virus is shed from the inflamed eye for about 2 to 3 weeks. Keratitis occurs in about 80% cases. Pseudomembranes or true membranes are a marker of severe conjunctival involvement. These true membranes bleed when removed, and their presence makes the patient uncomfortable. Membranes can also rub against the cornea, causing mechanical geographical ulcers that mimic herpetic keratitis. As in this image, we can see there is a patient of epidemic keratoconjunctivitis with membrane, and this membrane is being removed with the help of forceps. Follicles in a patient with adenoviral conjunctivitis, and the fluorescein dye demarcates the elevated follicles. This is another image in which there is lid edema and crusting of the eyelashes and presence of membrane. Now, we need to remember the stages of adenoviral keratitis. These are 4 in number. The stage 1, stage 2, stage 3, and stage 4. Supportive treatment. Supportive treatment for amelioration of symptoms is the only treatment required and includes artificial tears, preferably preservative-free, cold compresses, discontinuation of contact lens wear, removing any membranes or pseudomembranes, topical antibiotics, povidone iodine, which kills the free adenoviruses, or topical steroids for severe membranous or pseudomembranous conjunctivitis and subepithelial infiltrates. Corticosteroids enhance viral replication and increase the duration of viral shedding. Therefore, topical corticosteroid use is justified in cases with membranous or pseudomembranous conjunctivitis or iridocyclitis or severe keratitis and persistent subepithelial infiltrates which cause visual loss. Recently, zalcitabine, stavudine, and stampidine nucleoside reverse transcriptase inhibitors have been used with different degrees of anti-adenoviral activity. Also, topical antihistamines and vasoconstrictors can be used. Non-specific acute follicular conjunctivitis. The second presentation. Most common form of acute follicular conjunctivitis is this. It is caused by adenoviruses 1 to 11 and 19. Milder form of acute follicular conjunctivitis is this, and it causes unilateral symptoms. The other eye is involved 1 to 2 days later and very less severely. Patient may have systemic symptoms such as sore throat or common cold. This image shows the non-specific acute follicular reaction in the patient. It is milder, and the keratitis is limited to the epithelium, or most commonly, it is not present. Ocular signs are limited to mild follicular reaction, as we've seen in the previous image, or mild conjunctival hyperemia and discrete lid edema. It causes preauricular adenopathy. The identification of these patients is important per se because they might not seek medical assistance, and despite the benign presentation, these particular patients can serve as virus reservoir, spreading a not always benign disease in the community. Pharyngoconjunctival fever, it is due to the subtypes 3, 4 and 7, and it causes acute follicular conjunctivitis which is associated with pharyngitis. So patient may also have fever and preauricular lymphadenopathy. The cornea is involved, causing superficial punctate keratitis. This is transmissible by three routes: personal contact, fomites, or through swimming pool or ponds. Pharyngoconjunctival fever is one of the most common illnesses which is seen by physicians at children's summer camps. This is most commonly bilateral, and the eyes may be affected simultaneously or in sequence up to 3 days apart. Hyperemia involves the entire conjunctiva but is more prominent in the inferior fornix. This image shows a child with features of pharyngoconjunctival fever. Coming to the fourth entity, that is chronic relapsing adenoviral conjunctivitis. It is a rare disease, gives a clinical picture of chronic non-specific follicles or papillae. This can persist over years but is eventually self-limiting. The historical gold standard for adenovirus conjunctivitis is cell culture with confirmatory immunofluorescence. These symptoms persist longer than expected for typical cases of adenoviral disease, and the virus can be recovered many months or years after the onset. The conjunctivitis presents with intermittent bouts of ocular irritation with the waxing and waning superficial punctate epithelial keratitis and with subepithelial infiltrates. This image shows a patient with chronic adenoviral conjunctivitis, which shows a lid edema and thickening of the lid margin, that is stylosis. Coming to the next important entity, that is herpes simplex virus. It causes follicular conjunctivitis, particularly in primary disease. It is usually unilateral and associated with skin lesions. It causes minute to microdendrites, which may be mistaken for punctate epithelial keratitis, but the corneal sensation is reduced. The clinical course of the conjunctivitis is limited to 2 weeks. The initial signs are similar to adenovirus, but the majority of patients will present unilateral disease. Membranes and dendritic or dendrogeographic conjunctival ulcers are uncommon findings. The symptoms are itching, foreign body sensation, and lacrimation. Clinical features are different from those in severe cases caused by subgenera T, which are associated with pseudomembrane, membranes, or subepithelial infiltrates. The corneal involvement, such as typical dendritic keratitis, may be present at the first visit, or in some cases these may develop later, especially the immunocompromised patients or who have been treated with corticosteroids. The superficial punctate keratitis may be detected in patients without any dendritic lesions. The cell cultures are the gold standard method for detecting HSV. Treatment of HSV in the neonate is mandatory, and it should involve both topical as well as intravenous acyclovir. This image shows the characteristic herpes simplex virus keratitis demonstrated on fluorescein staining as well as vesicles in the same disease. Coming to the next, that is varicella zoster virus. It is a highly contagious disease, usually characterized by a mucocutaneous exanthem. Typically, lesions in various stages are present simultaneously, and the infectious period ends only when all the lesions are crusted. conjunctiva is rarely involved. It has small ulcerative, flictinule-like lesions at the limbus, which are the most common finding. And when the cornea is not affected, the patient can either be carefully observed without treatment or with topical antiviral ointments like vidarabine or 3% acyclovir for about 10 to 14 days. If keratitis is detected, treatment should be started. And this varicella zoster virus actually gains access to the sensory ganglia during the primary disease, which is also known as varicella. The reactivation of the latent virus in the trigeminal ganglion leads to involvement of the ophthalmic division of the trigeminal nerve and is referred to as the herpes zoster ophthalmicus. This image shows the corneal involvement in varicella zoster virus. Coming to the next, that is the acute hemorrhagic conjunctivitis. It usually occurs in tropical areas and it is caused by enterovirus and Coxsackie virus, which belong to the picornavirus family. It is rapid in onset and resolves within 1 to 2 weeks. The enterovirus type and the Coxsackie virus type 24 are the most common causes of acute hemorrhagic conjunctivitis. Although EKC, that is epidemic keratoconjunctivitis, with prominent subconjunctival hemorrhages may resemble acute hemorrhagic conjunctivitis, the latter has a shorter incubation time and a more rapid disease course and less corneal involvement. The treatment usually given is cold compresses and precautions of coming in contact with susceptible people should be prescribed. Next is the paramyxoviruses. It includes the viruses of measles, Newcastle, and mumps. Measles is a highly contagious viral infection. Transmission occurs via large respiratory droplets. The clinical features in the patients of these will have high fever, cough, runny nose, and a generalized maculopapular rash. Also, catarrhal conjunctivitis, superficial keratitis, and photophobia are the most common clinical features. Subconjunctival hemorrhages may be present in the patients. Keratitis is usually severe in patients with vitamin A deficiency. The two parts which come under the same are Newcastle disease and mumps. Newcastle disease is limited to poultry workers and laboratory personnel. Infection is acquired when the patient is dealing with infected poultry or directly with infected material related to owls. Ocular disease is characterized by mild follicular conjunctivitis and tearing. There may also be presence of subepithelial infiltrates. Mumps. It is an acute viral infection characterized by swelling of the parotid salivary glands. It causes orbital pain and a mass is present when the lacrimal gland is affected. Superficial punctate keratitis or stromal keratitis may be present. The next is molluscum contagiosum. It is caused by double-stranded DNA pox virus. Peak incidence of getting the virus is about 2 to 4 years, and the virus causes a typical skin lesion. When skin lesion is on the lash line of the lid, it causes viral shedding and follicular conjunctivitis. We examine the eyelash line carefully when chronic or unilateral eye irritation and mild discharge is present. The typical presentation of ocular involvement is follicular conjunctivitis and the lid margin lesions. These lesions are often raised, importantly umbilicated, and they are waxy and fleshy colored. This image shows the characteristic molluscum eyelid lesion. The treatment is usually surgical removal, which can be done by simple excision and curettage. Cryotherapy is effective, but depigmentation of the treated area is a risk. AIDS patients may present with exuberant or recalcitrant molluscum contagiosum. Meticulous surgical removal, electron beam radiation, carbon dioxide laser, and topical cidofovir can be effective in these patients. Remission can also be observed with administration of highly active antiretroviral therapy. So, now we'll discuss the overall investigations that should be done in cases of viral conjunctivitis, starting from gene sustain, polymerase chain reaction, viral culture, immunochromatography, serology for other causes in non-resolving cases. Reduction can be done by meticulous hand hygiene in household as well as in hospital settings. Avoid eye rubbing and towel sharing. Disinfection of instruments should be done and clinical surfaces after examination of the infected people.